My name's Tom McCarthy. I'm an improvement advisor here at Healthcare Improvement Scotland. So what I'm going to do is I'm just going to start the WebEx slowly and we'll see if anyone else joins us. So I want to do a round of introductions with the people sitting here in this room looking at me. So I'm going to start to my left and we've got Stuart. So do you want to start, Stuart, and just say hello?
Yeah, hi, I'm Stuart Ritchie. I'm a consultant physician at the Western in Edinburgh and also medical lead of Diabetes Think Check Act.
Hello, I'm Debbie Voigt, Diabetes Specialist Nurse in NHS Teesside, and I'm Lead Diabetes Specialist Nurse for the Diabetes Think Check Act project.
I'm Duncan Stein, podiatrist at NHS Lanarkshire and 2 days a week secondment with the Scottish Government as Diabetes Food Coordinator for Scotland.
Hi, I'm Kirsty Murray, Interim National Director, Diabetes Scotland.
Hi, I'm Lynn, I'm the Patient and NHS Engagement Manager for Diabetes Scotland.
I'm Scott Cunningham, Technical Consultant from Sky Diabetes.
Hi, I'm Kat. I'm the Project Officer for Diabetes Think Check Act here at Healthcare Improvement Scotland.
So I think that's just to help you get a bit orientated. So what we've got, you're going to hear from all of these people this afternoon, and you're not hearing much from me at all, so you're probably glad about that. Stuart's going to start us off and just give us a bit of a perspective on inpatient diabetes care from a kind of diabetologist perspective. And then Linda's going to talk through why inpatient diabetes care matters from a patient's perspective. And then there's a range of initiatives that have been going on that we'd like to kind of bring together for you. So one's about Diabetes Think Check Act, the CPR for feet, and development in Sky Diabetes. And at the end of that, we've got to have a bit some questions. Now, the program, we've got about 10 minutes, which it's a bit tight. The guys here have said that they're happy to kind of stay on the line a little bit longer, but we can see how we go. So I'm going to hand over to Stuart, and he's going to start.
Okay, hi everyone. I'm aware that we have a mixture of specialists in diabetes, but also perhaps some who are less versed in some of the challenges with inpatient diabetes. And what we thought would be helpful was to give a bit of background of why we are all here today. So we are here, I guess, as in the GAL representatives of the various inpatient work streams that have been progressed, specifically for inpatient diabetes over the last few years, and also we're here on the background of the letter that was sent to the NHS Board Chief Executives earlier on this month, looking for senior nominations in each health board to implement the inpatient diabetes care programmes in what says non-diabetes wards. I think most hospitals tend not to have diabetes wards at the minute, perhaps a reflection of the nature of diabetes in hospitals. So we hope to show you the areas that require improvement in our Scottish hospitals, but I think something not to lose sight of is to highlight the potential benefits from the work that's been done both to patients and to healthcare systems, both in better management of the core principles of good inpatient diabetes care, and to provide some solutions for that, and also make it clear that with the national inpatient coordinators there is support available to help each individual health board drive through change. So we have 3 patient stories in the next slide. The young lady on the left-hand side is called Alyssa, and her story will be told by College of Diabetes Scotland. But to set the scene, we know from all the various work streams and pieces of work that individuals have done throughout Scotland is that generally speaking 15 to 20% of our hospital patients have diabetes. What's unique about diabetes is patients are looked after in every single ward area in our acute settings, and the vast majority of patients do not come in directly as a result of their diabetes. Their diabetes is a secondary diagnosis. For example, the lady in the middle is an elderly lady who actually has very good glycemic control, very good glucose control in the context of type 2 diabetes. But her major challenge with her diabetes in hospital is that she's come into hospital with reducing mobility, and she's essentially immobile. And what's relevant for her is that she's previously had a diabetic foot ulcer. And that is healed, but she is at high risk of developing further ulceration. And that's actually her major risk being in hospital, is being immobile and developing a pressure ulcer with the associated healthcare adverse effects associated with that. And the gentleman on the right has been admitted for an emergency laparotomy. He's perforated his appendix. And although he hasn't been admitted because of his diabetes, the fact that he's on twice daily insulin injections is highly relevant to his care in hospital. And what's highly relevant is that he will undergo a period of fasting where his diabetes medication will need to be adjusted. And also with the stress of the intercurrent illness and stress of surgery, his medication will probably need adjusted in the post-operative period, especially as in cases there can be post-operative complications. So not only do the sort of peri-operative management when you're preparing somebody for surgery need to be followed, but also a response that if somebody becomes acutely unwell, that there can be a change to the treatment, ensuring good care for the individual. We like using data in the context of diabetes, and one of the recurring themes that will come through today is the power of data and how data can influence change. This is a slide that Debbie Voigt, my colleague, made, and what this shows somebody's journey through 3 separate inpatient episodes. And this is somebody with type 1 diabetes for almost 60 years. You'll see their HbA1c is 56 millimoles per mole. That indicates relatively good control in the outpatient setting, with an average blood glucose sitting somewhere between 6 and 9 millimoles per litre in general. And you'll see the blood glucose parameters on the y-axis. And you'll see across the various admissions how each yellow dot represents a blood glucose level. And you can see how during each admission there's such a huge range in the blood glucose readings between quite marked hypoglycemia with blood glucoses of 1.8 to quite marked hyperglycemia, indicating the stress of an intercurrent illness when somebody comes into hospital, and also a response to diabetes management and insulin management when somebody is admitted into our acute sector. So we've talked already about some of the information on this slide. It was interesting, I was looking at some data from the year 2000 which said 1 in 10 hospital inpatients had diabetes. Now we're looking at 1 in 5, and certainly nationally, looking at the national inpatient audit in England and Wales, we're consistently hitting a figure of 15 to 20% of our inpatients have a diagnosis of diabetes. 30 to 40% of those patients are insulin treated. Insulin, as we'll all be aware, is consistently in the top 3 high-risk medications, and unfortunately many of us are aware of adverse events across various health boards in NHS Scotland that have been associated with poor diabetes care. Inpatient diabetes has been prioritised by the Scottish Diabetes Improvement Plan. It's one of the key measures there. And I hope that we don't need to convince you today that many of the aspects for improving inpatient care very comfortably sit within realistic medicine and are very, very, they are optimising the key core aspects of good diabetes care in Scottish hospitals. Scotland doesn't take part in the National Diabetes Inpatient Audit, but it has been running in England and Wales for many years now, and it's been a powerful tool for change south of the border for inpatient services. It highlights a number of key measures around patient identification, number of patients in hospital, hypoglycemia, medication management, and also the management of foot ulcer disease as well. And it's a very, very rich resource of information. And some centres in Scotland have performed this audit in their own hospitals in the last 12 months, and I know from speaking to those centres that they have been very, very powerful drivers for change. What's apparent as well is that not only from the patient's perspective of better care, meaning better experience, there are undoubtedly healthcare system associated benefits with regards to improving diabetes control in hospitals. Most of the data has come around the management of hypoglycemia, and there's quite a rich body of evidence now showing that if you have hypoglycemia in hospitals, you stay in hospital for longer. And there is days length of stay and also cost per hypoglycemic episode, financial associations with that. One of the studies from 2015 from colleagues in England and Wales showed that each hypoglycemic episode in hospital that required third-party assistance, which included those where the staff nurse had to give the treatment, one of those episodes added £1,200 to the cost of the length of stay. And as part of Think Check Act, colleagues in Greater Glasgow and Clyde have done some healthcare analysis showing the potential benefits that if you improve the management of hypoglycemia, there are reductions in length of stay. So you may ask, how do we do at the current present time? So I'm aware of an acute trust that has about 1,500 beds, and this is their data. They are able to utilise their bedside capillary glucose data to show their performance. And I'll direct you to the two columns on the right-hand side, the grey and the pink column. The grey column is the number of hypoglycemic episodes that there has been in the last 4 weeks. So the measurement there is 635. And the pink column is the percentage that are appropriately treated. And it's interesting, we have looked at 3 large health boards across Scotland, and the pink figure generally sits in the areas that we've looked at, but sitting between 30 and 40%. So there's a clear area of improvement there to improve the management of hypoglycemia. What's interesting as well is if you look at the teal column on the left-hand side, these are the percentage of glucose readings where you don't have a kind number associated with it. If you don't have a kind number associated with it, you can't use that data point for your analysis. And I suspect that there are hypoglycemic episodes in that teal column which we aren't capturing. So there is room for improvement. Patients will come into hospital with hypoglycemia, but clearly one area that can be worked on is reducing the occurrence of repeated hypoglycemic episodes while somebody is in hospital. So I hope I've set the scene, and I'm going to hand over to my colleague Linda McGlynn to update you on the patient's perspective.